Craniotomy with elevation of bone flap, for multiple subpial transections, with electrocorticography during surgery. The multiple subpial transections are done to reach the areas in the cortex where a focal point of the seizures is identified, as in the frontal, central, or temporal region, and cut the horizontal fibers responsible for the seizure while preserving the vertical fibers responsible for motor and speech. Electrodes are prepared and placed on the brain. The electrical activity of the brain is recorded and mapped while the cortex is kept irrigated. The recording grids may be moved a few times to gain enough information about various sites. After the electrocorticography, the electrodes are removed and markers are placed. The cortex is pierced or incised with a curved probe at the adjacent sulcus of the gyrus identified as the focal point of the seizures. The pia is also entered and the gray matter underneath is transected in that area. The probe is removed and the same thing is repeated approximately a centimeter further along the identified gyrus for the extent of the seizure focus. Closure is done by suturing the dura and replacing the bone flap into position. Screws or plates are placed to secure the bone flap to surrounding skull bone. The divided muscles are sutured and the galea and the scalp are closed. Craniotomy with elevation of bone flap, for subdural implantation of an electrode array, for long-term seizure monitoring. The physician implants electrodes in the subdural layer for long-term seizure monitoring. A bone flap is elevated to implant a subdural electrode array along the cerebral hemispheres. The bone is replaced and stabilized. The scalp is anastomosed and sutured in layers. Craniotomy with elevation of bone flap, for removal of epidural or subdural electrode array, without excision of cerebral tissue. The physician removes an electrode array located in the subdural layer. The bone flap covering the electrode array is elevated and the array is removed. The bone is replaced and stabilized. The scalp is anastomosed and sutured in layers. Craniotomy for craniosynostosis, frontal or parietal bone flap. The physician performs a craniotomy for craniosynostosis. Craniosynostosis is a premature closure of the sutures of the skull. The physician incises and retracts the scalp over the fused suture lines. The frontal or parietal bones are removed. Craniotomy for craniosynostosis, bifrontal bone flap. The bones are reshaped and a bone flap is created from the harvested bones to enlarge and reshape the skull. If the dura mater was damaged during bone harvest, it is sutured closed. The reshaped bone flap is positioned and secured to neighboring bone. The scalp is reanastomosed and sutured in layers. Craniotomy for hypophysectomy or excision of pituitary tumor, intracranial approach. The physician uses a craniotomy to remove a pituitary tumor or resect a portion of the gland. The physician cuts and retracts the frontal scalp and raises a bone flap. The tissues are dissected to the sella turcica, and the pituitary is identified. The tumor or hypertrophic gland is resected. The bone is replaced and fastened. The scalp is anastomosed and sutured in layers. Hypophysectomy or excision of pituitary tumor, transnasal or transseptal approach, non-stereotactic. The physician accesses the base of the sella turcica through the nose. The incision may be made in the mouth underneath the upper lip to avoid facial scarring. A small hole is drilled in the skull base through the inferior aspect of the sella turcica. The pituitary is identified and the tumor or hypertrophic gland is resected. The hole is packed with gel foam, with or without bone chips. The nasal and oral mucosa are sutured closed. Craniotomy for repair of dural/cerebrospinal fluid leak, including surgery for rhinorrhea/otorrhea. The physician repairs a dural/cerebrospinal fluid leak. The physician determines the location of the skull fracture using an MRI scan. The skin over the damaged area is incised. A bone flap is removed to access the dura, which is sutured closed. The bone flap is replaced and stabilized. The scalp is reproximate and sutured in layers.